Hello, I am Parker Carte, and I am presenting Opioid Use Disorder, a multifaceted approach. Since the summer of 2019, Dr. Scott Galster, Vice Chair and Director of Applied Research at the Rockefeller Neuroscience Institute, or the RNI, and Professor of Neuroscience in WVU School of Medicine, has been my mentor. Before I start, I'd like to thank him for all his help, support, encouragement, and the incredible research opportunities. Opioid use disorder. When you think of that term, a number of things probably come to mind. Maybe you think of poverty-stricken neighborhoods. Maybe you think of an individual who can't get through the day without taking Xanax. Maybe you think of a family that is ripped apart at the seams because a young adult has fallen victim to opioid use disorder, or OUD. All of these examples are accurate representations of OUD. In fact, each of you probably knows someone who has or is living out this tragedy. Wherever you go in the United States, you will find opioid use disorder. The fact of the matter is that it's a pandemic. There's no other way to put it. Like many diseases, it does not discriminate between socioeconomic class, gender, or age. Anyone can fall victim to this horrible disease. In fact, 15 million people are suffering from OUD right now. 130 people die every day from OUD. And as some of you already know, West Virginia leads the country in opioid overdose mortality per capita with 49.6 per 100,000 people. That's comparable to the bubonic plague. While this is obviously very grim, there is hope. The Rockefeller Neuroscience Institute here at West Virginia University is currently working on groundbreaking research to combat this pandemic that has struck our home. I have had the privilege to participate in some of this research. Before we delve more into that, first, some history about the RNI. The RNI was established in November of 2017. Its purpose and mission are focus and dedication to improving lives by pioneering advances in brain health. As always, we must give credit to these individuals for helping establish this wonderful institute. First, Senator John D. Rockefeller IV and his family. Second, Dr. Gordon Gee, President of WVU. And finally, Dr. Clay Marsh, Executive Dean of Health Sciences. Simply, at the RNI, our mission is to improve lives by pioneering advances in brain health. Okay, this will be on the test. Is the opioid epidemic a problem or not? Well, yes, it absolutely is. It is a public health emergency. As I've already mentioned, 15 million people are suffering from OUD every day, and 130 people are dying every day. It's obviously very bad, and, unfortunately, West Virginia leads the nation. However, before we can actually do anything about it, we have to define our terms. We have to classify the problem. What is an opioid? Well, opioids are a class of drugs that are both legal and illegal. Obviously, heroin is in the illegal category, but other drugs, morphine, methadone, fentanyl, and oxycodone are legal prescription drugs. So then we have the D word, disorder. It's a hefty word that holds a lot of meaning. So what does it actually mean to have opioid use disorder? Well, obviously, you have to be misusing opioids, but you also have to be experiencing severe impairment or distress. It's actually a relatively new diagnosis, in fact, first published in the Diagnostic and Statistical Manual of Mental Disorders, or the DSM-5, in 2013. To clarify, the DSM-5 is the manual used for assessing and diagnosing mental disorders, combined opioid dependence and opioid abuse. In order to actually get diagnosed with it, though, you have to be experiencing 2 or more problems in 4 areas. Number 1, loss of control. Number 2, social problems. Number 3, risky use. And number 4, pharmacological problems, all in the span of about 12 months. As with any disorder, it exists on some sort of spectrum, hence the distinction between mild, moderate to severe you see here. Mild is 2 to 3 symptoms, moderate is 4 to 5 symptoms, and severe is 6 or more symptoms. Chronic OUD can lead to brain abnormalities. More than 2 million people suffer from OUD in the US and require extensive long-term medical treatment. There are signs and symptoms that can help identify someone needing treatment. These include, but are certainly not limited to, confusion, drowsiness, and weight loss. They can affect a person physically, emotionally, and mentally. Now, what can we really do about all of this? Well, there are treatments, and they vary. A lot of medical treatments run into problems when patients suffer from withdrawal and cravings. There's also therapy, counseling, inpatient and outpatient treatments, and treatments are often paired. The biggest problem, however, is that the traditional treatments are not always effective. As a result, new approaches are needed. One of the most recent at the RNI involves the use of deep brain stimulation, or DBS. The RNI is the first in the entire nation to attempt to use DBS on treatment-resistant OUD. The first patient was admitted on November 1st of 2019. Bear in mind that I had little to do with the DBS procedure, but I learned a lot about it and I was involved in some of the preliminary opioid research. Now here, I will briefly show a picture of the operating room where Dr. Razai performs the procedure. For patient confidentiality, I am not showing the patient's picture, but the patient's face is shown on a screen across the room to the right of where you see the whiteboard. Researchers in the room are tracking the patient's eye movements using eye motions tracking technology and software. And this is where I did work in training on this equipment and met with people at the RNI and Chestnut Ridge as they use the technology to work with patients in the trial. While the principal investigator was Dr. Ali Razai, the executive chair of the RNI, it is really a multidisciplinary project that involves experts from many fields. So what exactly is DBS? It involved a craniotomy in which an opening about the size of a nickel was made while the patient was awake to provide feedback to Dr. Razai. It's essentially a brain pacemaker, in which the neurosurgeon implants 4 tiny electrodes in very specific areas of the brain. In our patient's case, it was the nucleus accumbens, in other words, the addiction and reward center of the brain. When electrical impulses are administered, it regulates those structures of the brain, hopefully the way we want it to. It was a 7-hour procedure done on November 1st, 2019. Now, what will DBS actually do? Well, it sends a pulse current through electrodes implanted in the brain. It is believed that this will regulate the imbalance in the patient's reward circuitry. It may also prevent the patient's condition from getting worse. Without DBS, cravings can actually continue to become stronger. The physician adjusts the current using wireless technology. Stimulation to the nucleus accumbens is adjusted based on the patient's needs. It may need to be increased or decreased. One of the biggest points of doing this, aside from everything that you've seen thus far, is to ultimately put an emphasis on evidence-based treatments for OUD. Traditional treatments simply are not effective for all patients. The first phase of the clinical trial involved 4 patients. Selection criteria is very strict, and they must have failed at multiple levels of WVU Medicine's comprehensive treatments, such as residential treatment programs, outpatient treatment programs, medication, psychological interventions, and social recovery. Hopefully, DBS will be an effective and life-saving approach to OUD and eventually become the standard of care. Now we'll delve a little bit more into the use of DBS. While the RNI is investigating the mechanism for addiction, the U.S. Food and Drug Administration, or the FDA, has approved its use for other conditions such as Parkinson's disease, essential tremor, dystonia, epilepsy, obsessive compulsive disorder, or OCD, and the RNI routinely uses DBS for patients meeting these FDA guidelines. About 180,000 people worldwide use DBS as a treatment for FDA-approved diagnoses. The goals of the initial pilot study were to aim to demonstrate that the technique is actually safe. After that, a full-scale clinical trial can be conducted. This approach is directed at a very small percentage of opioid abusers. These patients have the most treatment-resistant opioid cravings. They face a lifetime of overdoses and relapses. They also typically have an inability to hold a job and many of the other severe consequences of addiction. The fact of the matter is, however, that we don't know everything about DBS. This is the entire point, though. We know DBS helps, but we also know that it's extraordinarily complicated. This is a large part of why this study was conducted. As Dr. Razai stated, quote, "The exact mechanisms are not known. By modulating the reward circuit, which relies on a chemical messenger called dopamine, you're getting better control. You're not craving dopamine as much," end quote. So yes, it's complicated. We don't understand it entirely, but we know that it helps. Is DBS for everybody? No, it's not. It's invasive. It's cutting edge. For now, it's for people who have been resistant to all other treatments. After all, it is brain surgery. Now we will turn our attention to focused ultrasound, another part of the RNI multifaceted approach to treating OUD. This is another experimental treatment. It involves the use of focused low-energy ultrasound. Don't worry, we'll get into what that means. But the first thing to understand is that it is a non-invasive approach and it has shown significant promise. First and foremost, one of the biggest challenges in treating any brain condition is the blood-brain barrier. The blood-brain barrier prevents things such as bacteria, germs, and also drugs from typically entering the brain. That's the whole problem, though, isn't it? How can we effectively treat conditions non-invasively without being able to administer drugs into the brain? Well, that is what focused ultrasound accomplishes. Here, I've outlined two different types of focused ultrasound. First is HIFU, or high frequency focused ultrasound, and LIFU, low intensity focused ultrasound. The RNI is one of the 5 places in the world to have both. High frequency ultrasound, or HIFU, has been around for longer than LIFU. It is used to ablate nerves at very targeted areas. It is non-invasive, so it is not brain surgery. For example, it is used for treating essential tremor, after, of course, all other treatments fail. It only takes about 2.5 hours. We've conducted the first procedure in West Virginia a few months ago. LIFU, on the other hand, is relatively new. It can also target a very specific location of the brain, however, without heat. Whenever you have HIFU, or high intensity frequency focused ultrasound, you create. In Alzheimer's disease, the target is the vasculature in close proximity to a beta amyloid plaque site. Beta amyloid is the protein commonly associated with Alzheimer's. Microbubbles are injected, and the LIFU causes those bubbles to oscillate at the target location, causing the blood-brain barrier to open temporarily, thus allowing larger molecules through that normally do not get through. These large molecules are thought to clear out those plaques. In addition, the LIFU is used to calm down overactive neurons near the nucleus accumbens. In this case, it does not open the blood-brain barrier. It uses low-intensity oscillating ultrasound waves to temporarily open the blood-brain barrier in other cases to allow for very specific and targeted drug treatment. As I said here, in simple terms, it shakes up dopamine production. We will now move on to repetitive transcranial magnetic stimulation, or RTMS. It is also a new experimental treatment that showed significant promise. Essentially, it uses magnetic waves to cause the stimulation of neurons in specific areas of the brain. This has been shown to actually decrease cravings in opioid addicts. This is another area where I was involved in cue reactivity research to help determine things that would be shown to a patient during their treatment. I will outline a course of treatment that was used on a patient with RTMS. First, the patient is shown a video of a person shooting up. This activates the patient's brain. The trial participant's brain becomes very active during this time in urges and cravings. At this time, RNI researchers use magnetic stimulation to reduce the cravings. The trial will continue to be expanded to include more patients in the future. Now, as we look at the goal of RTMS, Dr. Rezai sums it up very nicely. The goal is to, quote, reduce the cravings by modulating the reward center, or the craving center, of the brain in severe addiction patients, end quote. RTMS and OUD. So RTMS was used for OUD. It was administered in 7 separate sessions. It targeted the left dorsolateral prefrontal cortex, or the DLPFC. Again, cue reactivity was used, and substance-related cues were presented. Prior to, during, and following the RTMS sessions, that patient then engaged in subjective ratings. The patient then rated his substance cravings using a 100-point visual analog scale. Researchers then compared the patient's cue-induced craving ratings, and we found that there was actually a reduction in craving for heroin and cocaine. So, the patient experienced a decrease on average between 60% to 82% following 7 RTMS administration sessions. Of course, further investigation of RTMS is warranted. But, just to sum it all up nicely, RTMS was shown to decrease the patient's cravings. This is very significant. Finally, there is one last non-invasive treatment that I will briefly cover, medication-assisted treatment, or MAT for short. It has been effective in enhancing treatment retention of OUD. It resulted in a decreased frequency of opioid use. We now have a need to investigate novel interventions that will augment MAT. In conclusion, addiction is a very complicated issue. We are a long way from curing addiction, and just as far from truly understanding it. We do understand, however, that there are both genetic and environmental factors that play into who the unfortunate victim of OUD will turn out to be. In order to put this knowledge to good use, however, additional resources are necessary. We need to be proactive rather than reactive. Developing more aggressive treatments and ensuring that all individuals have full access to these treatments is the next step in fighting OUD. The RNI is the face of the future in treating opioid addiction. In the future, we hope to see wearable technologies that allow us to predict addictive behavior. We hope to enable the patient to take measures themselves to nip it in the bud, so they can stop cravings before they start. And we also hope to utilize virtual reality technology to better understand and treat addictive behavior. We hope to teach and enable those suffering from addiction how to get through cravings without turning to drugs. Dr. Zai talks about the future research at RNI. He says, quote, "We are going to take a serious approach to this, and we're doing it. We're going to try to tackle addiction in a coordinated fashion, but we have our work cut out. It's a very difficult problem, but we're not giving up because a lot of families need help." End quote. This is proof that there is hope. Change is on the horizon, and this is where it's happening. I could think of no better way to close this presentation than with a quote from Dr. Bazai. Quote, "We deeply care about our patients and families in West Virginia, across the country, and around the world. Our boldest aspiration is to make their lives better, one person at a time." End quote. Finally, these are my references. Thank you all for your time and attention. It was a pleasure presenting for you all today. I'd be happy to answer any questions, and stay safe and stay healthy. Thank you.